First, we're going to discuss gonorrhea. Gonorrhea. Gonorrhea was often confused with syphilis until the 19th century. In 2nd century AD, Roman physician Claudius Galen named gonorrhea for what he thought was its cause, an excess of semen. The disease is sometimes referred to as the clap, from the French word clapeur, meaning brothel. Signs and symptoms. In men, the symptoms are usually insufferably symptomatic. Acute inflammation occurs 2 to 5 days after infection in the urethra of the penis, causing an extremely painful urination and purulent discharge. Rarely, bacterium invades the prostate or epididymis, where scar tissue can leave the man infertile. In women, the symptoms are often asymptomatic, and 50 to 80% of infected women have no signs or symptoms of infection for years. Damage to uterine tubes becomes obvious when attempting to get pregnant, and about 25% of infected women suffer pelvic inflammatory disease. Pathogenesis. Gonococci adhere via fimbria and capsules to epithelial cells of mucous membranes lining genital, urinary, and digestive tracts of humans. As few as 100 pairs of cells can cause the disease. Does not attach to cells lining the vagina. Instead, they infect the cervix of the uterus. Gonorrhoeae can attach to sperm cells and travel to and past uterine tubes, causing pelvic inflammatory disease. Chronic infections can lead to tube infections, resulting in pregnancies outside the uterus or sterility. Gonococci can infect female urethra during sexual intercourse. Anal intercourse can lead to proctitis or rectal inflammation. Oral sexual intercourse allows infection of pharynx or gums, resulting in pharyngitis and gingivitis, most commonly seen in men who have sex with men. In rare cases, gonococci travel to joints, meninges, or heart, causing arthritis, meningitis, and endocarditis. And the pathogen and virulence factors, the Neisseria gonorrhoeae or gonococcus causes gonorrhea. For the epidemiology, gonorrhea occurs in humans only. The number of cases in the U.S. has been declining over the past 3 decades. Most cases occur in adolescents in southeastern states with multiple sex partners. Infection is 4 times more common among blacks than non-blacks and slightly more common among males than females. The risk of infection increases with increasing frequency of sexual encounters. Women have a 50% chance of being infected during one sexual encounter with an infected man, while men only have a 20% chance of being infected during one sexual encounter with an infected woman. The infection of elementary age children is strong evidence of sexual abuse by an adult. Diagnosis and treatment. Diagnosis. The presence of gram-negative diplococci in pus from an inflamed penis is sufficient for diagnosis of symptomatic gonorrhea in men. Commercially available genetic probes provide direct, accurate, and rapid detection of gonorrhoeae in clinical specimens for diagnosis of asymptomatic cases of gonorrhea in men and women. And treatment. In recent years, treatment has been complicated by worldwide spread of gonococcal strains that are resistant to penicillin, tetracycline, erythromycin, aminoglycosides, and fluoroquinolones. CDC recommends broad-spectrum oral cephalosporins to treat gonorrhea. There is no long-term specific immunity against gonorrhoeae, thus people can contract the disease multiple times. Prevention. Routine administration of antimicrobial agents to newborns' eyes to prevent ophthalmic disease. Chemical prophylaxis is ineffective in preventing disease. The use of antimicrobials to prevent genital disease may worsen the situation. Preventative strategies. Sexual abstinence, monogamy with a faithful partner, and 100% consistent and proper use of condoms.
Gonorrhea is common. There are about 500,000 cases of gonorrhea in the United States per year. Gonorrhea is transmitted through sex, either vaginal sex, oral sex, or anal sex. The complications of untreated gonorrhea in women include infertility, as well it can also cause pelvic inflammatory disease. In men, it can cause pain in the testes, or also known as epididymitis. And in both men and women, the organism can go to the bloodstream and cause further complications.
Today we'll be talking about syphilis. The history of syphilis is first recognized in 1495, led epidemiologists to hypothesize that Spanish explorers brought syphilis to Europe. Second hypothesis, the causative bacterium evolved from a less pathogenic strain endemic to North Africa and spread was coincidental to European explorers of the New World. Continues to afflict millions worldwide. Signs and symptoms of syphilis. Primary, small, painless, red and hard lesion called a chancery form at the site of infection. 10 to 20 days after exposure, typically form in internal genital, about 20% form in the mouth, around anus and fingers, lips, or nipples. Chanceries often unobserved, especially in women, where they form on the cervix. Secondary, sore throat, headache, mild fever, malaria, myalgia, lymphadenopathy, and widespread rash on palms and soles of feet. Rash may not itch or hurt, but can persist for months. Latent is this phase has no symptoms. Pituitary. Years later, untreated patients can experience dementia, blindness, paralysis, heart failure, or syphilitic gummies. Gummies are rubbery, swollen lesions that can occur in bones, in nerve tissue, or on skin. Rarely develop in patients in countries where antimicrobial drugs are available. Pathogenesis. Trip.
Pathogenesis of syphilis. Treponema pallidum must grow in humans and is transmitted almost solely via sexual contact, usually during the early stage of infection when spirosets are most numerous. Risk of infection from a single unprotected partner is 10 to 30%. It can be spread from mother to fetus, and it rarely can be spread through blood transfusion. It cannot be spread by fomites such as toilet seats, eating utensils, or clothing. Untreated syphilis has 4 phases. The first phase is primary. Canker forms and fills with the extremely infectious serum due to presence of millions of spirochetes. They remain for 3 to 6 weeks and disappear without scarring. Disappearance is end of the disease in nearly 1 of 3 of all cases. The secondary phase, if treponema invades bloodstream and spreads throughout body, a rash forms. Rash is also extremely contagious and gradually disappears after several weeks or months. The latent phase, clinically inactive phase of disease, majority of cases do not advance beyond this point if antimicrobial drugs are available. Congenital syphilis results when treponema crosses placenta from infected mother to fetus. If mother experiencing primary or secondary syphilis, fetus often dies. If mother experiencing latent phase of disease, fetus suffers mental retardation and malformation of many organs. Child usually exhibits widespread rash during first 2 years of life. Pathogens and virulence factors. Treponema pallidum causes syphilis. The epidemiology. Syphilis occurs worldwide. The WHO estimates more than 12 million new victims a year. Discovery and development of antimicrobial drugs has greatly reduced number of cases in the U.S. The CDC established a national goal for control of syphilis, maintaining an incidence of fewer than 0.2 cases of syphilis per 100,000 population in every county in the United States by 2010. In 1998, this seemed reachable, but reported cases increased 13.1% between 2007 and 2008 alone. Diagnosis, treatment, and prevention. For primary, secondary, and congenital syphilis, easy and rapid treatment using specific antibody tests against antigens of Treponema pallidum. MHA-TP test uses red blood cells artificially coated with Treponema antigens. For tertiary syphilis, extremely difficult to diagnose because it mimics many other diseases. Few spirochetes are present. Signs and symptoms may occur years apart and seem unrelated to one another. Treatments include the penicillin G, drug of choice for treating primary, secondary, latent, and congenital syphilis. Does not work for tertiary syphilis because it's not an active infection. No proven alternative for patients who are allergic to penicillin.
Syphilis is caused by a bacteria called Treponema pallidum. A lot of people think that syphilis has been gone for years, sort of like polio that's been eradicated in this country, but in fact, syphilis is on the rise. We see a lot of it. Symptoms of syphilis are going to vary depending on what stage a person is at. In primary syphilis, or the earliest stage of syphilis, people will have a sore called a chancre. But the interesting thing is that often people never see this sore. It's completely painless, it doesn't hurt, so if it's inside the vagina, inside the rectum, on the backside of the penis, people might not even realize that it's there. That allows syphilis to progress into what we call secondary syphilis, or the next stage, which can have vague symptoms, maybe just a rash or a low-grade fever. It can be very nonspecific. Then syphilis will enter into what we call a latent phase. And what that means is you still have syphilis, you can still spread it to other people, but you don't have any symptoms at all. Really, the only way to know you have it is to get tested. Now, unfortunately, there is a late stage of syphilis, which we call tertiary syphilis, and that can be very severe. That's when syphilis affects the brain, the heart, the eyes. It's a big deal for someone to get to tertiary syphilis. So if there's any concern that you might have been exposed to syphilis, get tested, because as long as we catch it early, in the primary stage, the secondary stage, or the latent stage, when it's not causing any symptoms, we can cure it without any bad consequences.
Now we're going to talk about staphylococcal toxic shock syndrome. Physicians first described toxic shock syndrome in the late 1920s, but the condition became an epidemic in the U.S. in the 1980s. Among menstruating women who use superabsorbent tampons, epidemiologists determined certain strains of Staphylococcus aureus cause this syndrome. Here are the different signs and symptoms. Some signs and symptoms consist of a sudden onset of fever, chills, vomiting, diarrhea, extremely low blood pressure, mental confusion, and a severe red rash. Untreated toxic shock syndrome is fatal to 50% of patients when their blood pressure falls so low that vital organs lose adequate supply of oxygen, which causes their shock. And then strands of Staphylococcus aureus cause staphylococcal toxic shock syndrome, which produces certain exotoxins, which are soluble poisonous toxins released from cells, which causes the toxic shock syndrome toxins. Then when these strands grow in the vagina or in a womb, the toxins are absorbed in the blood and they trigger the toxic shock syndrome. Researchers discovered that Staphylococcus aureus grows exceedingly well on superabsorbent tampons, especially when a blood-soaked tampon remains in place for a prolonged period of time. And then at risk, toxic shock syndrome occurs in males and females, but in most cases it has been identified in menstruating females. The U.S. Food and Drug Administration, the FDA, ordered certain types of superabsorbent tampons withdrawn from the market in the 1980s. And then they directed a reduction in the absorbency of all tampons in 1982, and they mandated packaging educational information to be on certain boxes of tampons. Then also, these government directives reduced the number of cases of toxic shock syndrome in the United States from 1,200 cases in 1980 to 78 in 2009. At-risk individuals include women who use tampons, vaginal sponges, or diaphragms, newly delivered mothers, surgery patients, especially after nasal surgery, and anyone with infection of Staphylococcus aureus.
Diagnosis and treatment. Diagnosis. Physicians diagnose TSS based upon its signs and symptoms. In some cases, cultures of blood samples grow with colonies of S. aureus. Treatment. Removal of foreign material, tampon sponge, diaphragm nasal packaging. Drainage of infected wounds. Supportive measures, IV fluid support, fetting blood pressure. Dialysis if kidneys are affected. Antimicrobial drugs. Vancomycin to reduce number of bacterial cells. Anti-TSST immunoglobulins. Counteracts the toxins. Prevention. Avoid vaginal insertions, highly absorbent tampons, vaginal sponges, birth control diaphragm. Use less absorbent tampons intermittently and for less periods of time.
Hi, I'm Dr. Mika Lane. I'm an OBGYN with Cascadia Women's Clinic in Vancouver, Washington. Today I'm going to speak with you regarding the causes of toxic shock syndrome. Toxic shock syndrome is a bacteria infection. The bacteria triggers the release of toxins that can go on to attack your internal organs and cause various medical problems. Ways that we can acquire or get toxic shock syndrome include the prolonged use of a tampon, meaning that you're leaving it in for more than 4 hours at a time, the use of a diaphragm for a longer period of time that's recommended by your healthcare provider, and also having a contaminated wound, cut, burn, or laceration. Toxic shock syndrome can affect men, women, and children, so we all need to be sure that we are vigilant about the care of our wounds. We need to be sure that we are washing our hands and keeping those wounds clean and dry. We also need to be sure that if we choose to use tampons, that we are changing those every 3 to 4 hours and that we're using a low absorbent tampon. If you have any further questions or concerns, contact your healthcare provider.